webinar is Youth Suicide Prevention, Recognize the Challenge, Take Action to Save a Life. We're so lucky to have Dr. Aruna Jha returning to present with us today. She is a suicide prevention researcher and specialist at the University of Illinois at Chicago. Dr. Jha, thank you again for being here, and let's get started.
Thank you very much, Kara. I know that we have a very short amount of time, and I'm very grateful to spend this hour with your attendees to this webinar. It's a privilege for me to present this information, and I don't know if the attendees were present at the last seminar or not, but I'm looking forward to presenting some new ideas and new ways to pass on the suicide prevention messages that are so important for our youth to hear, and for a way for us all to be present in the moment when we're trying to help youth and families.
Thank you, Aruna. We're going to get, before we begin, I just want to say that this is a follow-up webinar based on Aruna's last presentation when we received a lot of feedback from the audience around youth suicide prevention. We're really excited that she can be back here with us today. We have some polling questions that we're going to start out with today. And as a reminder, you can answer these questions on the right-hand side. There are 3 of them all in a row, and so they're all posted at once. But I'm going to take my time reading each one to you. The first one is, are you viewing this webinar by yourself or with others? So your options are by myself, with 1 other person, with 2 other people, with more than 3 people. We really want to get a sense of how many people are really watching these webinars. So if you can please answer that. Are you viewing this webinar by yourself or with others? By myself, with 1 other person, with 2 other people, with more than 3 people. The second question is, did you attend the last seminar presented by Dr. Jha? We want to see if you're returning or if this is your first time. Did you attend the last seminar presented by Dr. Aruna Jha? Yes, no, or I don't remember. And the third and final polling question for now is, have you had exposure to suicide prevention training before? Yes, numerous times, or no? Have you had exposure to suicide prevention training before? All these questions are on the right-hand side under poll questions, and you can just click the option that applies to you. We're just going to wait a minute for the results. Okay, it looks like most of you are viewing the webinar by yourself. And it looks like most of you did not attend the webinar before. Have you had exposure to suicide prevention before? Most of you said yes. Thank you so much for participating in that, and we will begin. Dr. Aruna Jha will go over the presentation outline.
Very good. Thanks a lot, Kara. So yes, these polling questions are incredibly important because I always have concerns at 2 different levels. One is not to be redundant. If you've heard these ideas before, I would like to come in with new ideas and new knowledge, since everyone's looking for new ways of sharing information here. But the second piece is also my concern about whether I have a sense of who's there listening to this webinar, and what your experience may have been with suicide prevention or actual suicidal behavior in people that you have worked with, or even in families, in your own family. And what I have found in about 20 years of doing this work is that regardless of the size of the audience, there's always a few people that have had personal experiences with this horrible tragedy. And it's important for the presenter to be aware that that might be the situation. I'm not asking you to let me know, but I just want you to hear me say, that I am thinking of you, and as I share my ideas, I will continue to think of you, and I want you as well to think about yourself and absorb the information to the degree that you're able to do it. So today we are going to be talking about youth suicide, and in all of the presentations that I've ever done, I think youth suicide becomes incredibly poignant, very important, because nature did not intend for young people to die. And those of us who are grown up and adult, have children of our own, work with children, know other people who have children or work with children, we feel the sense of burden when we hear of suicide death. So it's essentially a sad topic, and I just want to acknowledge that. And I see here in the polling question answers that almost all of you have had, there's one person who's said that they've not had any exposure to suicide prevention training, and 8 of you have given no answers. But suicide prevention trainings are being done a lot across the country, and most of the information that is shared is about how to recognize the signs of suicide and how to intervene with suicidal people. I will be addressing some of that too, but as the topic is about youth suicide, I want to focus on a critical element of youth development. And I think to the degree that we all start understanding how real this issue is, we will understand the challenge inherent in trying to control adolescent behavior, including risk-taking behavior. And risk-taking behavior actually elevates suicide risk. So I'm going to talk from a developmental psychology perspective and talk about adolescent brain development today, which I hope you will find interesting and absorbing, and it will give you some more tools to use as you speak on this topic with either your patients or other individuals. So we will cover some of the I'll talk about the scope of the problem and talk about adolescent development and apply 1 or 2 theories that I think are a good way to frame any discussions about suicide risk. And then we will review some of the guidelines for suicide prevention, because I think it's important to keep rehearsing them, not only for our own sake, but so that we are on top of our game, the game being suicide prevention, when we interact with other people. So again, very broadly, everything today is about creating a message that your constituents, your communities, your families, your patients will react to and respond well to. Because the one worrisome fact is that in suicide prevention, just doing awareness training actually doesn't lead to change in behavior. So we have to do more, and knowledge is the starting point for actually changing behavior. I'm going to move on to the next slide here and talk about the scope of the problem. As you can see, I tend to not read aloud from slides, but the real point is that when you look at the suicide rate here, my cursor is right there, you see that as age advances during the adolescent years, which is defined as 10 to 24 for this purpose, and these are CDC, the Centers for Disease Control statistics, it's very, very low. Very few young children die by suicide. And as they hit 15 and older, there is a sharp increase in the rates of suicide, And that is the important point for you to take. The statistics are from the most recent data that's available, so it's from 2010. And 4,600 is a large number. It's a large number of young people to lose. But the other take-home message is that we don't know, we don't account for all of the suicide deaths, because many of them go unreported, or many of them are misclassified for various different reasons. If you consider the total number of suicides in the U.S. as being a little over 38,000, it's actually 38,364, and they're continuing to rise, the number 4,600, you develop a perspective about it. And the reason why I'm bringing that up is because I think one thing we don't want to do is be alarmist. Because sometimes being alarmist backfires when you're really trying to encourage people to get over their own fears of engaging in suicide prevention. If you're too alarmist, you're actually going to make your audience be too afraid, and they're not going to want to do anything. So the fact is that they account for 12% of all suicide deaths, and it's a very, very tiny percent if you count deaths by all causes in the U.S. So in 2010, only 0.18% of all deaths were suicide deaths. You know, and if you look at the total statistic of 38,364, then those deaths were only 1.5% of deaths by all causes in the U.S. So fortunately for all of us today, the fact is that suicide deaths are not that great of a number. Having said that, though, I want to add a note of caution here, because suicide deaths are the end point, and it's the continuum that leads up to that end point that is important, because that's where we intervene. And so once again, going to CDC data and looking at high school students, which is the adolescent age range, these statistics here are worrisome. 16% of American youth in grades 9 to 12 in both private and public schools report seriously considering suicide. 13% report creating a plan. 8% report trying to take their own lives. And each year, 157,000 or more youth between the ages of 10 to 24 seek medical care for self-injury. And self-injury, you know, is often it's a suicide attempt. 20% of teens seriously consider suicide each year, and 1 in 10 college students has seriously thought about dying by suicide. The reason why these statistics are important, because when you balance what I'm saying now with what I said with the previous slide, that thankfully for us, suicide deaths are few, the fact is that the impact of these youth suicides or suicidal behavior in the communities in which youth interact on a daily basis, so schools, churches, families, you know, other organizations, this behavior and the outcome of this behavior has a much greater impact. And that is why everyone needs to be aware of how adolescents think, how they react, and what their impulses are for engaging in self-destruction. So let me give you a little bit more data here. Adolescent or youth suicidal behavior follows the same pattern as adult suicide. And in adults in the United States, men tend to die by suicide 4 times more often than women do. But women attempt 4 times more than men do. And so here what you see is that 81% of the suicide deaths among those 4,600 were males and 19% were females, and that's a 1 in 4 ratio there. But again, girls attempt suicide way more than boys do. The reason why girls survive their attempts more than boys do is because they use less lethal methods. The other important point, and you know, when I started to develop this training, Kara and I had talked, and she had said that there is interest in this group to address impulsivity and aggression in youth as a risk factor for suicide. So I've done my research and I'm bringing it to you here, but the statistics still stand that 90% youth who die by suicide are suffering from some kind of a mental disorder. And it's proportional. Most often they're suffering a mood disorder, and then it's substance abuse, and the combination of a mood disorder and substance abuse is the most lethal of all. So who are people who are especially at risk, and why is that? The highest suicide rate among young people is Native American males. And there, it's a coming together of social, environmental factors, substance abuse, plus a predisposition to think of suicide as being an option. Clearly there is a great need to have more prevention efforts targeting Native American communities. Surprisingly, African American males, the suicide rates are rising rapidly, and the phenomenon that we talk about often is suicide by cops or engaging in really high levels of interpersonal violence with guns being involved. Hispanic youth report making the highest number of suicide attempts, and there is less speculation about what the factors may be. But the fact is that Hispanic females, young Hispanic females, have the highest suicide attempt rate of any ethnic group. I do want to point out that this slide and the data has very little information about Asian American youth, and want to bring in my own personal commentary here that suicide is emerging as an issue in Asian American communities as well. And one study cited that in women aged from their low to mid-20s, Asian American women have the highest rates of suicide death. But that study is not widely cited. So are youth more vulnerable to death by suicide than adults? The data shows that thankfully the answer is no. Suicide is the second cause of death among young people after accidents, but that is not the same thing as saying that youth are more vulnerable than the adults are, because the rates for 100,000, which I'm going to show you, are the true statistics that we need to look at. It's not as if more young people are dying by suicide than older people are. The rates of suicide vary according to age. In childhood and early adolescence, we saw that in the previous slide, suicide is rare, and then it starts to increase in adolescence and young adulthood. The latest mean worldwide annual rates of suicide, so not just in America, but all across the world, per 100,000 were 0.5 for females and 0.9 for males among 5 to 14-year-olds, and 12.0 females and 14.2 males among 15 to 24-year-olds. So if you look at the teenage years and young adulthood, the risk ratio is 12 young women per 100,000 population and 14 males per 100,000 population. And now bear that in mind when you look at the next slide. And I want to point out bullet point 3 here, which is the range for people in general per 100,000 is ranging 12 to 20 suicides per 100,000 people. So that is to argue that youth are not more vulnerable to suicide than adults are. The youth is handled correctly and in the right environment. Youth tend to be resilient, and we need to think about resiliency, which is what this slide is talking about. And just think this through, that at any given point, 1 in 5 people is going to get depressed. Of those people who get depressed, 8,000, you know, so it's a reducing statistic here. 8,000 out of 100,000 will attempt suicide. And out of that 8,000, 12 to 20 people will actually die by suicide. So there must be something that is protecting 19,980 people who are depressed and 7,980 people who attempted suicide and then also survived. So what is that, and should we actually be thinking more seriously about this? So the research shows that suicidal ideation and behaviors occur both independently and together. And this slide shows you that not everybody who gets depressed gets suicidal. Not everyone that gets suicidal thoughts actually acts on the suicidal thoughts. And there's a very small number of people who have the thoughts and actually act on them. So research from 17 countries has suggested that those who have suicidal ideations have a probability of 29% of ever making a suicide attempt. But the real worrisome thing for mental health professionals is that the risk ratio rises once they've made the attempt. So a prior suicide attempt increases to 56% for those who have suicidal ideation and have formulated a plan. So almost half of the people who have the idea and have made a plan will actually attempt. But without this plan, only 15% will make an attempt. And what that suggests is that it's very, very important for us to assess whether the young people we're dealing with have actually made a plan of how they're going to kill themselves. And what I'm leading towards is the fact that we need to develop a comfort level in talking about this topic. Because if we don't ask that crucial question of have you actually made a plan, how would you die? We're never going to know who that 56% people are that are actually likely to attempt. In patients who, having attempted a suicide, 1 in 4 will make another suicide attempt in the next 7 years. So we in mental health, we're always concerned about how do we recognize which person is at a higher risk so that we can focus our attention on that individual. That is how you find out, and that's how you start taking the history. Have you had a prior suicide attempt? The risk of suicide in the year following a suicidal attempt is 30 to 200 times greater. So that it's not a question of just this one time that the individual is sitting in your office. If you know that a person has made a prior suicide attempt, you need to continue to track them for a very long time and continue to ask them about their thoughts. The progression from suicidal ideation to self-harm and then to suicide is not absolute. But of those patients who present to hospital with a suicide attempt, around 7% would have completed suicide in the 9 years that follow that attempt. So that is the way for us to understand what the pathway may be towards a death by suicide. Let's start talking specifically about adolescence. And I just want to say that I'm keeping my eye on the watch here, and maybe we will not be able to cover all of the slides that I put into this presentation. We will just focus on the key points for you all to take back and leave some time for question and answers. So my adolescence progressed normally, enough misery to keep the death wish my usual state, an occasional high to keep me from actually taking the gas pipe. So this individual is really reflecting on the turmoil and the despair that she felt in adolescence. The fact is that adolescence is a volatile period that takes both youth and parents by surprise. While many youth may pass through adolescence without event, there are many others that are swept up in an emotional state that they can't control. And in my experience in talking to various audience groups, not only in the U.S. but also abroad, what I have found is that few adults actually like to ponder, like to think about their own experiences as adolescents. And my bias is that if they would allow themselves to recollect and allow themselves to acknowledge their own difficult times, maybe that will become the basis of building an effective bridge to the young people in their lives. So if adults like to pretend that we don't have any vulnerabilities, and not acknowledging vulnerabilities actually in a responsible way prevents adolescents from confiding in us their vulnerabilities. So what is different or unique about adolescence, and why should we care? What I want to talk about here really is the onset of depression in adolescence and how that depression is rooted in brain development. And brain development is normative. We all go through the brain development, but we need to be aware of the process of that developmental phenomenon. Changes occur in almost every domain in a young person's life, from the physical to the psychological to the interpersonal to the social-cultural. And these changes start at puberty and end only when one is fully grown and is able to take on adult responsibilities. So instead of thinking of adolescence as only teen years from 13 to 18, because 18 is the age of emancipation, one needs to be aware that the brain development and synchronization continues way past 18. And for many, many people, it can continue through 24 and 25 years of age. And that is the realistic time frame to actually start considering, potential vulnerabilities. So the next question I ask is, are youth more vulnerable to depression than adults are? And there the answer actually is yes. So major depression disorder is common, and it's a serious disorder for adolescents. The lifetime prevalence increases dramatically from about 1% of the population under age 12 to 25% of the population by the end of adolescence. So it's almost as if being depressed in adolescence is a part and parcel of being an adolescent, The greatest surge in newly emergent cases occurs between 15 and 18 years. Cross-sectional and prospective epidemiological studies indicate that anxiety disorders often precede the emergence of depression and identify children at risk for developing depression. So becoming anxious first and then becoming depressed. It is possible that early anxiety and later depression share a common genetic basis with a different developmental time course. One study found that adolescent anxiety typically precedes onset of insomnia, whereas episodes of depression followed bouts of insomnia. So we have the picture of the typical teenager, young adult, staying up through the night, not able to sleep, having very scattered sleep patterns, not being able to cope up with schoolwork, etc. And taking note of the fact that that might be triggered by anxiety. And if anxiety is going to go untreated and the insomnia continues, that it would likely lead to depression. Adolescent depression, once it starts, follows a recurrent episodic course, with episodes averaging 7 to 9 months in those seeking treatment. So it's not a one-time phenomenon. It continues. And I would say that the environmental stressors actually add to the onset and the continuation of depression. The serious concern here is that once depression starts in adolescence, there is a likelihood that it will resurface at different points in one's life. And depression in adolescence is also associated with a family history of depression, with higher rates of suicide attempts, not only in the adolescent, but also in the family members, and an emergence of depression in adulthood. So treatment of adolescent depression is incredibly important. And unfortunately, there are limited options that we have pharmaceutically to treat depression, which is where we all as mental health professionals come in. Adolescents, it's known, respond better to talk therapies and to behavioral interventions than pharmaceuticals. Many adolescents do well on antidepressants as well, and I'm not talking against antidepressants at all. I'm advocating for doing both and. So can the depression by itself prompt suicidal behavior in youth? And the answer, again, we know this clinically, but the research also shows that it does. And in fact, depression is the key factor associated with the risk of repetition of adolescent self-harm and hence of elevated suicide risk. In the management of adolescents who harm themselves, careful assessment of depression and appropriate management of those who are depressed is essential. So I don't want to repeat stuff that you might already know from your practice. Hopefully we'll have time for some questions. But I do want to cite one study here because of the question related to impulsivity and aggression. So Renaud et al. Are a group in Canada, and they did a study where they compared 55 child and adolescent suicide victims to 55 community controls, and both groups were between the ages of 11 and 18 years. And they did semi-structured interviews and questionnaires with the family survivors of these children. And what they found was that the suicides were associated with depressive disorders, substance or alcohol abuse, and disruptive behaviors. Also, the suicide victims showed higher scores of life regression, impulsivity, and harm avoidance. When they looked at a logistic regression, so really parsing out even further what the significant predictors of suicide may be, the biggest predictor of adolescent suicide death was depressive disorders, and then came substance abuse, and finally the disruptive disorders. This is a relatively small study, but it does show that in comparison to other groups of matched case controls, suicide completers do have a higher tendency towards aggression and impulsivity. On the other hand, this particular study also showed that anxiety, comorbid anxiety, doesn't really increase the risk of suicide, did not increase the risk of suicide in this particular group. So now we have a picture of depressed youth, impulsive young people, and onset of aggression in this population. But my focus today and what I want to really point towards is that we need to figure out a way to bring this information into everyday communications with young people and the significant adults in their lives. So that's the direction that I'm going in terms of a theoretical framework to explain increase in youth depression, impulsivity, and aggression. behavioral theories actually fall in 3 domains, and I'm sure all of you already know this, so I'm not going to spend a lot of time on this. But they tend to be either sociological theories that look at the environment, look at peer influences, look at cultural identity as predictors of various behavioral outcomes, not just suicide, but I'm applying this logic to suicidal behaviors as well. You have psychological theories of attitude and behavioral prediction, personality development, or social learning. And then you have the integrative theories that actually combine everything that's out there to come up with some kind of a predictive model. And Brian Flay and his colleagues at UIC came up with this pictorial, of showing the 3 streams of influence on behavioral outcomes. So you have the individual here, and the individual is trying to make decisions and is trying to map out what they will or won't do. And you have the biology and the personality of the individual influencing those thoughts and those decisions. And then you have the cultural milieu that is also influencing those attitudes. And you have a social context that is prescribing what is or is not okay. So any one of these could be looked at individually or in combination to understand why young people are the way they are. But for today, and I think it's a powerful message, I found it effective whenever I've tried to advocate and speak up with suicidal individuals. And I'm going to really focus on biology and personality. And what amazes me is that many adults that are in the lives of young, depressed, suicidal people, and I have many examples coming to mind, they haven't quite thought of it in the way that biology and personality will explain it. And so there is a likelihood that there is an aha moment, and they become more accepting of, the responsibility involved in keeping the young person safe. That's basically what I want to say. So that is why I believe it's important to be well aware of biological influences on depression and suicidal behavior, as well as aggression, and to be able to talk knowledgeably about them in our day-to-day work. So the thing that I want to highlight here is that adolescent brains are not fully developed, and where they are not fully developed, or which parts of the brain are not synchronized, is what dictates the onset of the behaviors that we've been talking about, as in depression, impulsivity, aggression, risk-taking, and substance abuse. So adolescence is a time when symptoms of a variety of mental illnesses manifest, including mood disorders, eating disorders, schizophrenia. During this period, there is a vast array of neurobiological changes that drive everything from a cascade of hormonal signals that initiate puberty to increased cognitive ability and motivational changes. So the neurobiologists actually look at the onset of puberty as a key milestone in adolescent development for the development of all of these behavioral outcomes. 2 particular observations about brain development in adolescence are especially pertinent to our understanding of psychological development during this period. First, much of the brain development during adolescence is in the particular brain regions and systems that are key to the relation of behavior and emotion. So adolescents are likely to act in a much more emotional manner than in a self-regulated, controlled, rational way. This is also related to the perception and evaluation of risk. Second, it appears that the changes in arousal and motivation brought on by pubertal maturation precede the development of regulatory competence in a manner that creates a disjunction, a dysynchrony between the adolescent's affective experience and his or her ability to regulate arousal and motivation. So they feel, in simple terms, they feel quicker than they think. In contrast to most measures of cognitive development in adolescence, which seem to correlate more closely with age and experience, rather than the time of pubertal maturation, there is evidence for a specific link between pubertal maturation and developmental changes in arousal, motivation, and emotion. So literally the onset of puberty starts the chaos, and we all have said this at points in our lives, I would imagine. It's the hormones, it's the hormones, it's the hormones. And yes, it's true that it is the hormones in a lot that are influencing a lot of the choices that adolescents are making. So for example, there is evidence that puberty influences the development of romantic interest and sexual motivation. There is also evidence that some changes in emotional intensity and reactivity, such as changes in frequency and intensity of parental conflict, and that's the piece that I also want to focus on, is triggered in adolescence by puberty. So what is the take-home message for all of this? Sorry, I'm going to jump through the next 3 slides here. Give me a second, sorry. The take-home message here is adolescents cannot help acting the way they do. Their emotions control their behavior. Expecting them to listen, obey, or act rationally is not realistic. Shouting at them or using other forms of violence induces the aggressive, impulsive behavior that is often self-directed, but can also be other-directed, as in recent acts of homicide and suicide. It behooves the adults to stay calm and use strategies to de-escalate the stressful situation. These are my biases, guys. This is what I believe. This is what I say to people all the time. The goal of every interaction with adolescents should be containment, and it is for us as adults to take the initiative in containing adolescent behavior. We need to be wary of complacency when adolescents are being medicated. The risks are high at those times, and I will talk briefly about some examples here from real life. As professionals, our treatment plans have to include outreach and education of parents. We have to address the stigma and sense of shame and guilt in the family system, just as we have to also address the potential for intergenerational transmission of suicide risk. We have to enlist the help of an extended support system. We have to encourage and train children to confide in the appropriate adult or official when they need assistance. And that should start right in childhood and continue all the way through adulthood. We need to not keep secrets. We have to suggest to troubled youth that we will support him or her as he or she starts a conversation about his suicidal past with the mother or father. I've had personal experiences of young people saying, I'm coming to tell you this, but please don't tell my parents, or please don't tell my friend's parents. And we need to not buy into that. If needed, we have to bring the parents or go find them and tell them about our concerns related to their child. In fact, including parents in the treatment is a critical component. We have to be aware of contagion risk. When organizing memorials, we have to be careful to follow media guidelines. of not glamorizing, not sensationalizing, not overstating the details of what happened, but focusing instead on prevention messages and resources. We have to pay attention to the various warning signs that might be triggered by the moodiness that accompanies adolescence, because this moodiness can be life-threatening. Sudden changes in mood and behavior, talking of death, dying, giving away possessions, saying goodbyes. I believe we all have an awareness that for young people particularly, these are serious indications and need to be explored. Expressions of death wish in writing and poetry, we have to especially pay attention to those and ask the young person to sit down with us and tell us what lies behind that poetry or that essay. Prevention can and should start early and occur in any and every context of interactions with youth. You know, sometimes young people will say things in a joke, but as adults, we have to still say, wait a minute, what exactly do you mean with this? In many schools today, readings of Romeo and Juliet are followed by a discussion of the appropriate actions that should have or could have been taken. The role played by peer pressure, the youth-adult divide, the generation gap as is shown in that play, and secrecy in the ultimate death of the protagonist. We should do the same in the context of other stories, films, and plays that we all watch and that we know our youths watch, and books that they read and they obsess about. We could talk for quite a while, but not today probably, about medication management. You know, I want to share with all of you a particular tragedy that I was made aware of, and where I went in and actually did a post-vention with the family. The deceased was 18 years old, had just started university. The father was a physician. The young man was under psychiatric care. He was an antidepressant, but had started to feel somewhat better. And on the day that he died, the family really believed that he was going to be okay when he said to them that he'd rather stay home, whereas they all had to go to a family event. I think the family truly believed that the antidepressants were working. It's very, very sad for me to share with you that when they came back, they found him hanging in the basement. You know, so we know about black box warnings, but what do we do to educate parents about the potential side effects of medication and the need to be extra vigilant? I want to share with you the incident of another 16-year-old girl who had just entered high school, and her intent to die was, with hindsight again, quite lethal. So she tried to find a weapon. She tried to fool one of her classmates who she knew had a weapon in the house to bring a weapon to school. Unfortunately, the classmate refused to do that. But then she went home and she overdosed. She was not taken to a hospital because, again, this was a healthcare provider family, and they thought they were managing it appropriately. Her stomach was pumped and she fell asleep. This kind of situation, as you all know, can cause a lot of fatigue on family members, but in the middle of the night, the mother went to check in on her and found her not in the bedroom, went looking for her all over the house, and found that she'd hung herself with a rope in the garage. So I think vigilance and all of the elements of watchfulness and companionship and being in the same space with seriously depressed and suicidal young people, we can't reinforce this enough. And yet what we try to do on a day-to-day basis is, you know, balance our desire to not be alarmist with our concerns as healthcare providers about the risk in our patients and our clients. So again, my message is the same. We are reaching almost the end of the hour, that what we need to focus on more and more is educating parents, educating teachers, and starting the dialogue among ourselves about how adolescent brain chemistry precurses a lot of the adolescent behavior, potential for depression, and suicide. I will not go further than this because I want to see if there are any questions you all have to ask. Or comments for that matter.
Thank you, Aruna. Thank you so much.
Yeah.
Really taking your time to share with us all of your expertise on this really important topic. I'm wondering if anybody has any questions. If you can chat them in the chat box, we would be happy to have Aruna answer questions or concerns or comments that you have. There's also an option to raise your hand. Since there aren't very many attendees, if you want to raise your hand, we could unmute you, and you could also talk to Dr. Aruna Jha if that would be easier. Any questions or concerns? You can chat them and send to all panelists in the chat box. I sent everyone a chat to let you know that you could chat in the chat box earlier. You could chat questions, concerns, comments, or you could raise your hand and we can unmute you.
Okay, so
somebody has a comment, Aruna. Gabriel said that the stories are very moving. Thank you so much for including.
Thank you. Thank you, Gabriel. Thank you.
I agree. I agree.
You know, my sense of this, Kara, is that the topic is heavy, and I hope that I've given people a way to frame their interactions and conversations, and maybe even got everyone to think a little bit differently so that we ourselves understand the phenomenon a little bit better, because the better we understand it, the better we are able to address it, you know.
Mm-hmm.
1 hour is a very short time, and there's a lot that could be covered in this lecture, and I haven't done that. I do want to, and maybe you want to do that, Kara, alert people to the fact that there are a resource slide that will be part of the PowerPoint when it's loaded, and there are many sources where you can get more information, you know, and if you're not already connected with those websites, I would encourage you to go there because you can get a lot of information. And that is the www.suicidology.org. You know, get into the website for the Centers for Disease Control and look at the violence prevention section where suicide also is listed. And www.SPRC, that is the Suicide Prevention Resource Center, is another good website to go to if people are looking for more information. And also, of course, in New York, you have the American Foundation for Suicide Prevention, which is a good place to start if you're looking for both resources and information.
Yes, thank you. There are some questions and some more comments. And again, I just want to thank you again because I really appreciate even the title of this presentation, Take Action to Save a Life. So I think it is heavy, but it's also really, really important. So Jonathan has a question. Would you recommend the use of a standardized assessment tool for adolescents, such as the Columbia Suicide Scale? If so, for what ages would the tool be used?
Okay, yes, Jonathan, I think using a questionnaire is helpful. And the Columbia screen, I believe, is self-administered. So correct me if I'm wrong. If you can just post your comment to that, Kara can speak up and let us know. But, the real issue is that the conversation that goes along with the assessment is probably way more important than the assessment itself. Any assessment is just a starting point. And my experience with pencil and paper measures has been that people tend to report quite accurately what they think and feel, whereas we as providers often think that they will fudge their answers. Now that may or may not be true for young people who are really very afraid of intrusiveness. So the take-home message is use the assessment, but use it in conjunction with other assessments that you do verbally with the student or with the youth or even the family members of the youth. Don't rely solely on the assessment measure.
Okay, great. Somebody else had a comment kind of along the same lines. Thank you for all the important info, Rosalba had said. I think it is important to keep in mind that we need to do continued assessments for kids that have prior attempts and ideations. Do you agree with this, Aruna?
Absolutely, and I thought I kind of said the same thing when I was citing some of the statistics about how the risk rises exponentially for someone who acknowledges a past attempt. And I'm going to link that to what I'm saying, what I said in my response to Jonathan, that sometimes the young person is not your source of information. You will get the information from somewhere else. So you still need to weave that into your diagnostic interviews and interventions and continue on a regular basis to check in, almost as if, you're training the young person to start talking about their own thought patterns and start tracking their own thought patterns in a regular manner, in a normative kind of a way. Yep, I agree.
Yeah. Great.
Mm-hmm.
To wrap up, we had some questions about the slides and about the websites you mentioned. I just want to remind everyone that the slides will be available at our website, www.ctacny.com, ctacny.com. If you go onto our website and click Lunch and Learn, Clinical Lunch and Learn, all of the slides from any of our webinars will be available there, including today's. Today's will be at the top of the list. Also, somebody asked about the websites that you mentioned. I just wanted to let you know there's a resource page at the end of the webinar. Are you there, Aruna? Can you go to the?
Yes, ma'am.
So those are the websites that Aruna had mentioned that you can find. And then if you want to go to the next page, I just want to remind everyone that our next webinar will be on December 11th with Dr. Elizabeth Meeker, who will be returning to talk to us about trauma treatment. I hope that everybody has a wonderful day. Thank you so much for your presentation, Dr. Aruna Jha, and thank you so much for everybody who participated today. Do you have any last comments for anyone and everyone?
Well, I'm just grateful. I'm grateful to all the people who logged in today, and I hope that this is a community of listeners that will start interacting more actively and regularly with CTAG and hopefully with me as well.
Great. Okay, so until next time, everyone, have a wonderful day. Take care. Bye-bye.
Thank you.